Good afternoon, I'm James Jackson. I'd like to welcome you to this webinar. We'll be talking about shoulder arthroplasty. I'm the new orthopedic resident, or sorry, not a resident anymore. I am a new orthopedic attending here in town. Just finished up my fellowship over at Houston Methodist, where I trained under the doctors who took care of the NASA astronaut corps, the Houston Astros, the Houston Texans. I was an assistant team doc for Rice University. I was also a team doc for 5A high school in Texas. Had a nice season, went to quarterfinals. I did my residency up in Dayton, Ohio. Spent 5 years there. I performed over 2,800 surgeries. Just real excited to be joining the Lake Charles Memorial system. Came here for some great opportunity. There's a lot of young athletes that like to perform in many different sports. Spent last night at the football jamboree. I'll be there again tonight, helping out on the sidelines, trying to keep our athletes healthy. But I also take care of the older population. As we start to age, our joints start to break down. And one of the things I enjoy most is kind of the shoulder, either rotator cuff repairs, but I also enjoy shoulder arthroplasty. It's something I did in my fellowship as well as my residency. And we're building a great team to kind of take care of the shoulder, from the young athlete, the throwing athlete, to the older individual whose shoulder is just kind of broken down and the only option left is to replace it. And we're going to talk a little bit about the different types of replacements today. It's a little taste of two flavors, as I call it. So we'll get started. If you have any questions at any time, please type them in at the bottom and we'll get to them at the end. So shoulder arthroplasty, a taste of the two flavors. I have no disclosures. I don't get any royalties from any of the companies. There'll be some x-rays in there. Just to start off, we'll start with a little history of shoulder arthroplasty. The first documented case was actually in 1892 over in France. It was made of platinum and rubber, and it was by Dr. Jules Pien. And you can see kind of a crude redesign of that total shoulder here on the film. And it did well for about 2 years, and then it got infected. Rubber's not the best material to put in the shoulder, but this was the first case. And it kind of fell to the wayside for a while. We talk about getting into the modern area where Dr. Charles Neer, he practiced up in the Northeast, and he really started doing these for proximal humerus fractures. We have a big problem with proximal humerus fractures. They're difficult fractures to fix, so sometimes if they're broken up enough, we kind of throw them in the bucket and we put in something new. But this is kind of Dr. Neer's design. It was a single piece prosthesis, and he just put it on the humeral side. In 1974, he started implanting it for arthritis. He started putting not only the implant you see here, but he also started putting something on the cup side, on the glenoid side. So talk about the shoulder being a ball and socket joint. He was originally just putting in the ball. Now he's putting in a new socket. And you can see that socket here. This is a modern day glenoid component, or not modern day socket component. And these are our modern day implants. There's a lot of modularity, you can see. So when we go and do this, it's not like Dr. Neer's first implant, which was just one solid Vitalium metal implant that we put down the humerus. We've got all kinds of different pieces that we fit together to make sure that our patients have the best fit, and we try and get close to your original anatomy as possible. But sometimes we change that anatomy, and we'll talk about that here in a minute. So we talk about modern day implants. So on the left, you can see kind of what Dr. Neer's implant looked like, and maybe what his glenoid kind of looked like. It's this big prosthesis, singular piece. And then on the right, we can see how we've kind of shrunk those implants down. We have better materials now that allow for better on-growth. And this is an anatomic total shoulder. And we'll talk about the difference between anatomic and reverses. This is also kind of on the left, you can see this big prosthesis, and you can see the white around the prosthesis coming down the humerus, and that's cement. So a lot of these were initially cemented, and cement's not a bad thing, but we've gotten some better technology now that we allow for better press fit total shoulders. And on the right there, that's a reverse total shoulder. We've actually changed the anatomy a little bit, if you will. We've put the ball where the socket was and the socket where the ball was. And that changes how we do that. And this is kind of the modern day father of reverse shoulder arthroplasty. Dr. Pien's original design was a kind of a reverse total shoulder, but this reverse total shoulder, the modern day, was done by Dr. Paul Gramont, another gentleman from France. And you can see that he's put the ball on the socket and a socket where the ball was. And this changes the biomechanics of the shoulder. We'll get into that a little bit. So really it comes down to, why do we perform total shoulders? You know, here's an image of a nice shoulder. You can see a nice ball and socket joint. You can also see a little bit of the joint space is well maintained, but shoulders do go bad. And here on the right, this picture coming up, that's end-stage glenohumeral arthritis. That's arthritis between the ball and socket. The shoulder does have multiple joints, and sometimes people get what we call AC joint arthritis, acromioclavicular arthritis. And that's something different. That really only bothers very few people, and maybe some bodybuilders, but almost everybody got a little bump over here. If you did some heavy lifting, I got a couple myself. But this is glenohumeral arthritis. We also have indications with when we do fractures, like we were talking about Dr. Neer and his original way of putting these in. And when you get really bad fractures, like you see on the left here, this is a proximal humerus fracture. There's multiple pieces here. These are really difficult cases, and sometimes we take a patient's age into consideration, their bone quality, and how many fractures. Putting a new shoulder may be a good surgery for that patient. On the right, that ball is no longer in a socket. And that ball is no longer in a socket because the rotator cuff has torn. And we'll talk a little bit about the rotator cuff tear in a minute, but the rotator cuff is four muscles that stabilize the joint and hold the humeral head down and assist with motion. And when we lose that rotator cuff, the humeral head will actually start to rise. So that's a sign, and we call that rotator cuff arthropathy. So which is right for you? You know, well, it depends. Do you have glenohumeral arthritis? Do you have rotator cuff arthropathy? Or do you have a really bad fracture? Each one of those cases is separate. So an anatomic total shoulder, but you have to have a good rotator cuff. You have to have a good cuff to be able to maintain that. I mean, we're trying to recreate the anatomy God gave us, but that means we have to have some other things that God gave us and keep our joints strong. And this is the rotator cuff. And this is just a diagram showing the supraspinatus, the infraspinatus, the subscapularis, and the teres minor. The supraspinatus is the one we often associate with rotator cuff tears. If someone comes in and tells you they got a rotator cuff tear, it's usually the supraspinatus, and that assists with arm abduction, raising the arm up. All right. Now you can have a massive tear of the supraspinatus and still have a good joint and still move, but because you have some other muscles that assist with that. The infraspinatus helps you to externally rotate your shoulder. The teres minor actually externally rotates the shoulder when your arm is up. So the ladies who like to get to the back of their head, for me, I like to rub my bald head. But we also have a little subscapularis. The subscapularis helps you internally rotate, helps you pull things and keep things close to your body. It's actually about 60% of the bulk of the musculature of your rotator cuffs, and it's often neglected. And this is just an MRI view. And this is an MRI view kind of where they're cutting you from the outside in. And this allows me to see the glenoid, the little shape in the middle that looks like a pear. That is the socket. All right, and then you can see the musculature. The A is the musculature of the supraspinatus, B is the musculature of the infraspinatus, and C is the musculature of the teres minor. D is the subscapularis. So all of those are something we look at to make sure you're intact there. And often before if we're talking about going down a road of shoulder replacement, if you don't have that rotator cuff arthropathy, if that head is still well seated, well, sometimes we'll send you for an MRI of that shoulder, because on the left here you can see where those arrows are pointing. There's that nice black line coming right to left over the ball there and connecting to the outside of what we call the greater tuberosity. And on the right you see the white arrows and you see some white. That white on the right image is fluid, and that fluid is sitting where your rotator cuff used to be. So that rotator cuff's torn. So if we're talking about a total shoulder arthroplasty and we're talking about an anatomic, it's not going to work because we need your rotator cuff to power that prosthesis. And also, we also give that MRI sometimes. On the left, to evaluate the muscle, on the left you see a nice muscle. It looks like a nice lean steak. On the right, however, the white is fat. And you can see that that muscle has now become fat, infiltrated with fat. And that's evidence of a really poor rotator cuff. So again, probably not the best to put an anatomic in you. We talk about why if you got a rotator cuff tear, why do we go to a reverse shoulder arthroplasty? Well, Dr. Pien and Dr. Gramont and several leaders here in the States have really done a lot of biomechanics studies. Just came back from a course in Tampa where we talk about this all the time. And what it does is it takes the stress off what used to be your rotator cuff and it puts the stress on your deltoid being the muscle we feel on the outside of our arm. And it puts the stress on there and it stretches it to a point to where now it has a biomechanical advantage. And now we, instead of using the rotator cuff to start to elevate our arm, we use the deltoid. All right? So if it comes in, if you have glenohumeral arthritis, we used to always say you get an anatomic total shoulder, but the lines have been blurred over the last few years. It used to be that we did about 80% anatomic, putting the ball where the ball is, the socket where the socket is, and 20% reversing everything. Well, now that number's flipped, and we do about 60% to 40%. So 60% are reverse shoulders and 40% are anatomics. And people are asking, well, why? Well, they're technically easier. I mean, it's an easier exposure surgically. We don't have to worry about the status of the cuff. If we're just going to a reverse, well, we don't have to worry about getting an MRI. If we don't have to worry about the rotator cuff healing. At the bottom, there's a diagram. You see all those sutures. You see that's the subscapularis. We have to cut the subscapularis, take it off so we can access the joint. And then we have this complex repair, and then we have to slow you down a little bit more early in the rehab process so we can heal that muscle, because again, that's the major muscle that helps with that internal rotation of your shoulder. And we don't have to worry about glenoid loosening as much. There's a lot with the anatomics. We are putting a plastic and we're cementing it in. We've got some better technology, so we're doing a little bit better. But with the reverse, we've got a metal and we're putting screws right into your glenoid. But nothing's perfect. So in my practice, if you have glenohumeral osteoarthritis and you're less than 75 years old with an intact rotator cuff, this is what you're getting. I've talked to several leading docs about this in Florida, also in Houston, and they all say the same thing. A good anatomic shoulder, it will outperform a reverse total shoulder any day of the week, especially in the young, active population. But if you got a bad cuff, we're probably going to go with a reverse. It only makes sense. So, and then we talk about advances. We've gotten really advanced over the last several years. We have 3D planing software. We have 3D guides. We have augmented base plates, and the base plate is the item down on the bottom right. When the socket doesn't always wear uniformly. It doesn't always wear into just a degraded cup. Sometimes it degrades a little more anterior, sometimes it degrades a little more posterior, and we've got a plan for that because we have to kind of correct your anatomy so you don't dislocate, and that's a problem with total shoulders, is them dislocating. And now we've got these nice little change and reamers, things that drill the bone and make it into a better socket, so I can put something there that matches your old anatomy to compensate for any bone loss you may have on the glenoid. And we have these vitamin E polyethylenes. The plastic that we send is melted, it's irradiated, and during that process, they used to wear out a little bit because they'd have little free radicals. If you're a diet buff, you'll know about free radicals, but they'll have little things that cause destruction within the polyethylene, so they'll wear. But actually, they put vitamin E, an antioxidant, into the polyethylene. When I take them out of the package, they got this little greasy feel to them, and they're yellow. But that's something else we're doing. So here in Lake Charles, I'm doing all these. I've got the 3D planning software. We've got 3D guides. We've got augmented base plates, and we're putting in vitamin E polyethylenes. And on the bottom left, you can see a little image of what that 3D guide looks like. So, you know, it's a tight spot in the shoulder. So as you can imagine, if I got something that helps me put your glenoid in the right place, I'm going to use it. On the right, this is before you get to surgery, weeks before you get to surgery, we look at your shoulder. I can actually use augmented reality and move your shoulder in time and space to see how much range of motion I'm going to get, see where I'm putting the screws, see how I'm going to place that central pin that's going to guide everything else I do. So the question really becomes, is an anatomic or reverse right for you if you got a bad shoulder? And really that's going to be a discussion between you and your doctor. And that's going to be a discussion for your workup. CTs are often ordered, MRIs are often ordered. So I thank you. This is a picture of my wife and kids. We were at Glacier National Park last year trying to avoid the COVID shutdown, but it was a nice little trip. We slept outside, by the way. Any questions, please put them in the bottom. I'd be happy to answer them. All right. Well, I appreciate your time. And if any of y'all listen, I really appreciate all the pulmonologists and the critical care staff that are working overtime up in over here in Lake Charles Memorial and across the state and across the country. They're really doing a tremendous job to keep people out of the ICUs and then get people out of the ICUs. So it's been a rough time for everybody, but Lake Charles Memorial is dedicated to keeping the community safe, and if you come in here, we're going to take the best care of you possible. So, but thank you to all the critical care nurses and everybody working on the floors. They've been working hard and working overtime, and it's been a blessing to have those people.